Hello everyone. Here we are going to discuss a very important topic, that is inflammatory bowel disease. Basically, we will be discussing two important inflammatory bowel disease here, Crohn's disease and ulcerative colitis. In your university exam, you frequently get a long question as well as short question on any of them. That is Crohn's disease and ulcerative colitis. Both are ultra important. So we will be discussing the gross, microscopy, clinical features, complications of both of them, and we will compare them back to back. Here you can see we are starting the topic, that is inflammatory bowel disease. So Crohn's disease and ulcerative colitis we will be discussing. First, I will let you know what is inflammatory bowel disease. What is inflammatory bowel disease, also known as IBD, inflammatory bowel disease. Then I will tell you the two types, that is Crohn's disease and ulcerative colitis. We will see the epidemiology. Then we will start them separately. I will call Crohn's disease as CD and I will call ulcerative colitis as UC. For each of them, I will tell you the introduction, their most common sites in the bowel, their gross, their microscopy, clinical features, complications, and the mnemonics, easy mnemonics to learn them. So let's start it. First, let me tell you what is IBD, inflammatory bowel disease. What do you mean by that? As the name indicates, this is a disease which results from mucosal immune activation. So in the bowel, the mucosa immune system get activated, and that leads to immune mediated chronic inflammatory response in the bowel. And that is the meaning of the inflammatory bowel disease. Two important types are there. Crohn's disease, that is CD, and ulcerative colitis, that is UC. Crohn's disease, ulcerative colitis, we will be discussing them one by one. Before that, let me tell you the epidemiology of both of them together. So most common age of presentation, both UC and CD have bimodal peak. They occur either in the young age, that is 15 to 30 years of age, and the second peak is in the old age, that is 60 to 80 years of age. So both UC and CD, they occur either in young age, that is 15 to 30 years of age, and the second peak is in the old age, that is 60 to 80 years of age. Gender, male is to female ratio. In CD, it is more common in males, 1.8 times more common in males as compared to female. But UC, that is ulcerative colitis, is equal in male and female. So that is regarding the gender. We have seen the age, we have seen the gender. Now rural, urban prevalence, they are more common in urban population, in the cities, in urban population as compared to villages, that is the rural population. Socioeconomic status, they are more common in high socioeconomic status as compared to low socioeconomic status. And there are two important risk factors, the smoking and OCP uses. These are the oral contraceptive pills use. These are the risk factors for them. So we have seen the age, gender, rural urban ratio, socioeconomic status, and the risk factor. That is all about the epidemiology. So learn the definition, learn the types, learn the epidemiology. Now we will start the detail one by one. Let's start Crohn's disease quickly. Crohn's disease. What is Crohn's disease? Crohn's disease is a type of inflammatory bowel disease. It's a type of IBD which is having relapsing and remitting course. So sometimes the patient have exaggeration and sometimes the patient is perfectly all right, that is remission. So relapsing and remission course is there. So for few days, few months, the patient have the symptoms. For the next few days, few months, the patient is asymptomatic. So that is relapsing and remitting course the person is having. This is Crohn's disease. Now, what is the most common site in the entire bowel? What is the most common site? The most common site is terminal ileum. Most common site is terminal ileum, followed by ileocecal junction, second most common site, and followed by cecum, the third site. And after that, it can occur anywhere. It can occur in any portion. These are the three most common site. So most common site you can see here. We will mark again. Most common, I will write 1 here, that is terminal ileum. I will write 2 here, ileocecal junction, and I will write 3 here in the cecum. So this is the sequence you can see. Terminal ileum, followed by ileocecal junction, and followed by cecum. That is the most common site. Now coming on the gross, there are few points we have to learn in the gross. The most important point regarding Crohn's disease in the gross is that skip areas are there. What do you mean by skip areas? You can see the disease is here. This portion of the bowel is involved, then this portion is asymptomatic. Then this portion is involved, then this portion is asymptomatic. Then this portion is involved, then this portion is asymptomatic, likewise. So some portions are involved, some portions are asymptomatic. So this is like gross, the skip areas are there. Skip areas are there. You can see here, the skip areas are there. So this is the gross. You can see this is the gross and skip areas are there. So one portion is involved, then one portion is normal, then one portion is involved. So skip areas are very common. In Crohn's disease, it is not continuous. It is opposite of continuous with the skip area. So this portion is involved, this is normal. This is involved, this is normal. So this is involved, this is normal. So these are the skip areas. Second thing in the gross you have to learn, the portion which is involved, like this portion is involved, this portion is involved, that portion, the wall become thickened. In that portion, the wall become thickened and lumen become narrow. The wall get thickened, the lumen become narrow, it looks like a pipe. Which pipe? It is known as hose pipe or string sign. It is known as hose pipe. So this portion, the bowel become thickened walled and the lumen become narrow. Wherever there is an involvement, that portion, the bowel become thick walled and the lumen become narrow. That is known as hose pipe and string sign. So learn the skip areas, learn the bowel become hose pipe. Now learn the ulcers. Now, what is the disease? Actually, you can see the disease in the terminal ileum. See, this is the terminal ileum. So in the terminal ileum, you can see multiple ulcers are there, which are snake shaped. These are known as serpentogenous ulcer. So the shape of the ulcer is like this. These are known as serpentogenous ulcers are there. So the serpentogenous ulcers you can see. The ulcers are like snake, serpentogenous ulcer. Now you can see, please understand, this is the ulcer, this is the ulcer, and this is the ulcer. Between two ulcers, this is the ulcer, this is the ulcer. Between two ulcers, the mucosa swells up. What I'm saying, please understand. So this is the ulcer over here, this is the ulcer over here. This is the ulcer, this is the ulcer. Between the two ulcers, the mucosa swells up. So you can see it gives a cobalt stone appearance. What are cobalt stone? Now this appearance is known as cobalt stone. You can understand it here like this is the ulcer, this is the ulcer, this is the ulcer. Between the ulcer, the normal mucosa swells up. So it is giving an appearance of cobalt stone. So multiple stones are placed. It is known as cobalt stone appearance. So intervening, surviving mucosa swells up between two ulcers. And that gives cobalt stone appearance, never forget. So this is the cobalt stone appearance we have seen. After that, the ulcers are very deep. Now you can see this area is involved, this area is involved, this area is involved, the skip areas are there. If I take the biopsy of any of these areas, it is like this. You know the four layers in the GIT, mucosa, submucosa, musculus propria and serosa. You all can appreciate this is mucosa. This is mucosa. Just below that submucosa, musculus propria, you can see the pink color musculus propria, this one. This one is musculus propria and you can see the serosa. Okay, now you can see where is ulcer. What is ulcer? The breach in mucosa. What is ulcer? So you can see the mucosa is continuous, continuous, continuous. Here there is a breach. So I can see a ulcer over here. I can see a ulcer over here and I can see a ulcer, a breach in mucosa over here. So you can see the mucosa is continuous over here, continuous, continuous. Now there is a breach. Again, continuous, continuous, continuous. There is a breach. Again, continuous, continuous, continuous. Again, there is a breach. So multiple ulcers are there. So ulcers are very deep. They are through and through. They are very deep. They are very deep. They involve mucosa, submucosa, sometimes musculus propria and serosa also. So these are known as fissures. The ulcers are very deep. Deep fissures are present. Deep ulcers are known as fissures. Sometimes through and through. Through and through they perforate and they form the sinus. So ulcer go deepen, 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 deepen. It will perforate and it is known as sinus. So the fissures leads to the sinus formation or fistula formation. So fissures leads to fistula and sinus. And multiple bowel adhesions are there. At places strictures are there. Can you see a stricture? This is a stricture. So narrowing of the bowel at the diseased area. You see terminal ileum is strictured because multiple ulcers are present. So here it is strictures are present. Multiple granulomas are there. The entire involved area is studded with multiple granulomas. Hundreds of granulomas are there. And creeping fat is very common. The fat is creeping fat. So this is the gross. What we have learned in the gross. Number one, skip areas are there. Appreciate the skip areas. Number two, hose pipe. Hose pipe is there. The involved area become thickened and the lumen become narrow. That is hose pipe. Serpentogenous ulcers are there, which is giving cobalt stone appearance. You can see deep fissures are there. Deep fissures, which is leading to sinus, leading to fistula, adhesion, stricture, granuloma, and creeping fat. So this is the gross. So tell me, enumerate the gross of CD, gross of Crohn's disease. Can you enumerate the important finding? You have to draw it in the diagram. Number one, I will say the skip areas. I will draw it in the diagram, multiple skip areas. Skip areas are common. After the skip areas, I will draw the hose pipe. I will draw the thickened bowel with a narrow lumen. That is hose pipe appearance. After the hose pipe appearance, I will draw the ulcers which are serpentogenous in shape. Serpentogenous ulcer, the snake-shaped ulcer, which give cobalt stone appearance. Cobalt stone appearance because of the intervening mucosa becomes swelled up. After that, the ulcers are very deep, which are known as fissures. Sometimes they become through and through, leading to sinus formation and fistula formation. Fistula formation. Granulomas are very frequent. Granulomas, strictures are very frequent, and creeping fat is there. So you have to draw it and label it in a diagram. This is all about the gross. Now coming on the microscopy of the Crohn's disease. In the microscopy, see the four layers: mucosa, submucosa, musculus propria, serosa. Let's start with mucosa. Let's start. So can you see this is the mucosa? It's continuous, 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 continuous. Oh my God, there is a discontinuity. Again, continuous, 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 continuous. You can see here continuous, continuous. Again, there is a discontinuity. So I can see two ulcers. A A breach in mucosa is an ulcer. So I guess I can see an ulcer over here, a deep ulcer, a breach in mucosa, and I can see an ulcer over here. So you can see the 4 layers. See the mucosa, submucosa, muscularis propria, and serosa. There is a mucosa. Just below that, there is submucosa. There is muscularis propria, and there is serosa. So you can see this is continuous mucosal lining is there. Just below the mucosal lining, so in the mucosa, you can see the ulcerations are there, which are very deep. Now you can see in all the 4 layers, see the mucosa, submucosa, muscularis propria. This is muscularis propria, and serosa is not shown here. You can see the inflammatory cells. Can you see the lymphocytes all throughout? These all are lymphocytes. I can see the lymphocytes in submucosa also. I can see the lymphocytes in muscularis propria also. So all the 4 layers have inflammation. It is known as transmural inflammation. All the 4 layers have lymphocytes and plasma cells. That is the inflammatory cells. In the submucosa, special thing is present. Let me highlight. Can you see in the submucosa the structure? What is the structure? Can you see in the submucosa what is the structure? In the structure, can you see giant cells are present? This is a giant cell. This is a giant cell. These are the epithelioid cells. Oh, this is a granuloma. So in the submucosa, granulomas are common. And in the background, can you see the pink color in the background? That is edema. Let me highlight the edema. Can you see the background? So background is having pinky color. That's pinkish color is the edema. So that is edema. Edema is also very frequent. So learn. So you have to draw it. You have to draw it. How you will draw it? You will draw the mucosa and you will draw a gap in the mucosa. That will be the ulcer. So you will draw a deep ulcer. A deep ulcer. That is a fissure. Deep fissure. After that, I will draw the submucosa. I will draw the muscularis propria. And I will draw the serosa. Now I will draw the inflammatory cells, the lymphocytes everywhere. The lymphocytes in the submucosa also, in the muscularis propria also, in the serosa also. I will label it as transmural inflammation. In the submucosa, I will draw a granuloma. I will draw few giant cells and maximum epithelioid cells. And this is a granuloma. This is a granuloma. I will label it as granuloma. So I will draw the transmural inflammation, granuloma, and a deep ulcer, that is a fissure. So that is the microscopy. This is how I will draw it in my exam. So the same thing is shown to you. Coming on the clinical features. There are 2 types of clinical features, intestinal and extraintestinal. In the intestine, patient have painful period, I mean the symptomatic period and asymptomatic period. It's the, remission and activation of the disease. So intermittent attacks, when the patient have the symptom, patient have diarrhea, fever and abdominal pain. And right quadrant pain is there because of the terminal ileum involvement most commonly. Bloody diarrhea may be present, bloody diarrhea. So these are the symptoms. But after the symptomatic period, there may be a long asymptomatic period also. In extraintestinal manifestation, the eye can be involved, the uvea of the eye, uveitis, the joints can be involved, that is migratory polyarthritis, sacroiliitis can be involved, ankylosing spondylitis can be there, erythema nodosum, the skin have the rashes, and clubbing of the fingers can be there. So these are the extraintestinal manifestation. In the intestinal manifestation, diarrhea, abdominal pain and fever. And in extraintestinal manifestation, uveitis, polyarthritis, erythema, nodosum, ankylosing spondylitis in which the vertebra is involved. So these are the extraintestinal. Among the complication, patient have iron deficiency anemia because blood is lost in the urine. Patient have malabsorption because intestine is not absorbing properly. Stricture formation, fistula formation, perforation, hemorrhage, and asymptomatic amyloidosis can be there. So these are the complications. So if you want to learn everything about Crohn's disease, I am having a mnemonic for you for easy learning. So the mnemonic is sister in CCF. Congestive cardiac failure, CCF is sister in CCF. So sister, S stand for skip lesion, I stand for ileum is the most common site. One more S is the string sign or radiology. T is transmural involvement, transmural inflammation. Inflammation is present in all layers. E is extensive fibrosis. R is rectum is spared, usually spared. Sister, IN, I is intermittent attack. N is non-kidneting granuloma. CCF, cobalt stone appearance, creeping fat and fistula. So if the mnemonic helps you, it's good. If you don't require a mnemonic, you can learn the gross and microscopy separately. So that is regarding the Crohn's disease. Now coming on the ulcerative colitis. In ulcerative colitis, there is continuous involvement. There is also exacerbation and remission. Like the CD only, here also exacerbation and remissions are very common. Exacerbation. Here rectum is involved. Here most common site is rectum. Can you see? It's not terminal ileum, it's rectum and it's in continuity. No skip area. In contrast to Crohn's disease, here continuous involvement is there. In Crohn's disease, if you remember, skip areas were there. Here no skip areas, it's continuous involvement. Number 1. And number 2, what is the most common site in Crohn's disease? It was terminal ileum, ileocecal junction and cecum. But here the most common site is rectum. It starts from rectum and ascend upward. Sometime it involves the complete colon, complete large colon, and it goes in the small intestine. It is known as backwash ileitis. Peck wash ileitis. Ileitis in which the ileum is involved from backside. So it is backwash ileitis when the complete large intestine is involved and the disease is progressing towards the small intestine, the ileum. So backwash ileitis is there. So that is the site. Coming on the gross. As I told you here, continuous involvement, no skip areas. You can appreciate the continuous involvement here. You can appreciate the continuous involvement here. You can appreciate the continuous involvement. No skip areas. No skip areas. Now here, the area in which the disease is there, that part of the bowel become dilated. In contrast to Crohn's disease, where that part become constricted, that part become narrow. Here, that part become dilated. So it is looking like a pipe, but this pipe is known as garden hose pipe. Garden hose pipe. That was known as horse pipe. This is garden hose pipe. So that is this part of the intestine is dilated. Now here the ulcers are very superficial. Superficial ulcers are there. Can you see superficial? Ulcers are not deep. Can you appreciate here? The ulcers are very wide and they are very superficial. Can you see? In contrast to CD where deep ulcers were there, here ulcers are very superficial. The width is more, the length, the depth is less, but the width is more. So ulcers are superficial. And between two ulcers, this is ulcer, this is ulcer, the mucosa swells up. And it is looking like a polyp, but this is not a polyp. This is a normal healthy mucosa which swells up. It is known as pseudopolyp. So instead of cobalt-stone appearance, here we have pseudopolyps. So this is the ulcer, this is the ulcer. Between the two ulcers, the mucosa swells up. It looks the appearance of a polyp, but it's not a true polyp. It's known as pseudopolyp. This one is pseudopolyp. Now coming on the microscopy of the UC. In the microscopy, can you see where is the ulcer? So see the continuity of the mucosa. So this is mucosa, mucosa, mucosa. This is all about the mucosa. This is all about the mucosa. This is all about the mucosa. So here you can see this is all. So in this segment, the mucosa is missing. So this is ulcer. I can see the ulcer is superficial. It is not deep in contrast to CD. The ulcer is very superficial. So first thing, the ulcers are superficial. Fissulas are absent. Sinuses are absent. No fissures, no fissula, no sinuses. Here inflammation is there, but inflammation present superficially only in the submucosa. It is not present in muscularis propria. See, no inflammation in the muscularis propria. So inflammation is also superficial. So inflammation is also very superficial and the inflammation is not transmural. It is not present in all layers in contrast to CD. And inflammation contains the neutrophils. There the inflammation was containing lymphocyte. Here mainly it is having lymphocyte plasma cells but neutrophils also. And one of the things which is present in submucosa, which is special here, in the submucosa, what is the structure? Can you see the structure? What is the structure in the submucosa? So you can see this is villi. The elevation is villi. This is crypt. So we have villi, we have crypt. This is villi, this is crypt. This is villi. These are the crypts. So just below the crypt, there is an abscess, a collection of neutrophil. Can you see a collection of neutrophil? These all cells are neutrophils. A collection of neutrophil here. It is known as crypt abscess. It is known as crypt abscess. They are very common. Crypt abscess is common. So that is the microscopy. So we have seen the microscopy of both. Now coming on the clinical features. I will draw the microscopy both together. Clinical features of UC. We have intestinal and extraintestinal. In the intestinal, I told you exacerbation and remissions are there. During exacerbation, bloody diarrhea, mucoid material, abdominal pain, cramps, the symptoms are same as that of CD. But extra manifestation in the musculoskeletal migratory polyarthritis is there, sacroiliitis and ankylosing spondylitis, which were there in CD also. In the eye, uveitis is there. In the skin lesion, erythema nodosum is there. In the liver, primary sclerosing cholangitis is there, and DVT can be there. So most of the extraintestinal are also same in UC and CD. So the organs involved is musculoskeletal, eye, skin, liver, and DVT. So that is the thing. Among the complication in UC, toxic megacolon is there. If complete colon is involved, it's toxic megacolon. Electrolyte imbalance, hemorrhage can be there, and rare of the rarest, it can be convert into malignancy. CD never convert into malignancy, but there is a rare chance less than 1% UC can convert into malignancy, colorectal carcinoma. Now to learn all the features of UC together, I'm having a mnemonic for you if you want the mnemonic. The mnemonic is cold tip. The mnemonic is cold tip. C stand for crypt abscess. O stand for originates in rectum. L for limited to the colon, mucosa and submucosa. D for distortion of the crypt and deletion of the mucin. T for toxic megacolon. I for increased risk of the colon cancer, and P for pseudopolyps. I know the mnemonic is not very good and I don't think it's very useful, but if some student require, I'm giving you the mnemonic. Otherwise, mnemonic is not required if you have understood it completely. So let's complete and back to back fill UC and CD. So tell me the introduction. It's a disease. Here also exacerbation and remission is there. Here also exacerbation and remission is there. Both of them are inflammatory bowel disease in which the bowel get inflamed. Tell me the site. In CD, the site is terminal ileum, followed by ileocecal junction, followed by cecum. Here the site is rectum. It always starts from rectum, always, and go upwards, go ascends upward. Tell me the gross finding. Here gross is big. Here, first of all, in the gross, I will say skip lesions are there. And here I will say it's continuous involvement. Here the bowel become thickened, the lumen become narrow. That is known as hose pipe. Hose pipe. Here the bowel become dilated and the lumen widened. It is known as garden hose pipe appearance. Garden hose pipe. Instead of hose pipe, say garden hose pipe appearance. This means constricted, this means dilated. Apart from that, here the ulcers are serpentiginous, which between two ulcers, the mucosa swells up and it gives cobalt stone appearance. Cobalt stone appearance. Here the ulcers are very superficial, and between two ulcers, the mucosa swells up. It gives pseudo polyp appearance. So here we have cobalt stone, here we have pseudo polyp. Apart from that, in CD, we have fistula, fissure, sinus, granuloma, stricture. All these features are absent here. Creeping fat, all these features are absent here. So that you have to learn grossly. Now, microscopy I will draw for both of them. I will show you the microscopy of both of them. You can see the gross also here. Can you see CD and UC? This is CD, this is UC. You can make out here the skip lesions are there. You can make out this one is continuous. You can make out here the most common site is terminal ileum, followed by ileocecal junction, followed by cecum. Here the most common site is rectum. Here you can see the ulcers are very deep. Here you can see they are very superficial. Here you can see between two ulcers, the mucosa swells up. It is known as cobalt stone appearance. And here between two ulcers, the mucosa swells up. It is known as pseudopolyp. So you can see the gross features here very well. Now coming on the microscopy of both, this is CD, this is UC. Appreciate the microscopy. First tell me the ulcer. So see the ulcer here. I will highlight the ulcer in both of them. See the mucosal lining. Where is the breach? So you can see here is the breach. Here is the ulcer which is deep. Here is a breach. Here is a ulcer that is very deep, deep ulcers. And here ulcer is very superficial. So deep ulcers are there and superficial ulcers are there. So deep ulcers and superficial ulcers are there. Deep ulcers and superficial ulcers are there. Here the ulcers are deep. Here the ulcers are superficial. Okay, now see the inflammation in both of them. Here inflammation is present in all layers. Here inflammation present only superficially. So here the inflammation is transmural, present in all layers. Here inflammation is very superficial. Superficial inflammation is there. Now one thing is present in the submucosa which is special in both of them. Let me highlight. Here what is this? Here what is this? Tell me. Both of them are different. So here this one is a granuloma and this one is a cryptapsis. Cryptapsis. I assume you know how to draw granuloma. In the granuloma, you have to show the giant cells. So these are the giant cells you can see with the epithelioid cells. In the cryptapsis, you have to draw collection of neutrophil. So this is a collection of neutrophils. That is what you have to show it properly in the microscopy. After the clinical features, both of them intestinal, extraintestinal, intestinal, extraintestinal. The same. In intestinal, it is bloody diarrhea, abdominal pain in both of them with remission and exacerbations. In extraintestinal, there is uveitis. There is ankylosing spondylitis and migratory polyarthritis. So these are the extraintestinal main symptoms. Complications you have to learn. Mnemonics, they are of no use as per se me. I don't learn the mnemonic. I can understand it like this. With the help of the diagram, it will be easy for me as compared to mnemonic. But if you require the mnemonic, I have given you the mnemonic also. Here the mnemonic is sister in CCF. SISTER, sister in CCF. You can learn the full form. And here the mnemonic is cold tip. If you want the mnemonic. If you don't want the mnemonic, it's okay. Learn with the help of the diagram. It's more easy to learn with diagram. So have a look. The same thing is written in front of you. You can compare UC and CD like this. That's all about it. So if question is coming on CD, write that only. If question is coming on UC, write that only. If question is coming a long question on IBD, write down both. And in the end, make a comparative table, draw well-labeled gross diagram and microscopy diagram of both of them. That's all about it. Don't forget to check all the university exam questions of this topic, which is given in the notes as well as question bank. Thank you.